Infodemic management is basically at the frontier of the public health practice. And this is what Liz and I would like to guide you through. What does the intervening actually look like? So this is the Infodemic Manager's Intervention Toolbox that we've prepared. And we'd like to spend about half an hour talking about this until we get to listen to several examples and then do a group exercise. Liz, are you ready?
Let's do it.
Great. So you've heard over several sessions now, as we've been discussing together, that really what we as Infodemic management are, we are the glue. We actually dot connect between different parts of the public health system, between our health system that don't necessarily always talk to each other, but actually are addressing different parts of the infodemic elephant. So we dot connect between the health programs, the emergency response structures, risk communication, community engagement functions, and we really try to ensure that they have the insights they need, and also that we complement that and that we create an enabling environment through the public health system so that their interventions, their actions, their objectives are more easily met. And so the way that we need to be always thinking about infodemic management is that actually the bulk of our work happens in the preparedness part, outside of the emergency. Systems that we strengthen, connections that we make, the types of things that we can do in routine time, so that then through this system strengthening and the enablement of healthy behaviors, when emergency hits, we have the capital, we have the practices, we have the connections already set up so that we can more effectively respond in an emergency. And this is why this step number 3 of the process that we are going through in the training is really important. And as you heard Howard speak about human-centered design, the takeaway message also from his talk for me is that human-centeredness is not only about looking the client, who are you serving, who are you trying to reach or adapt or influence behaviors from. It's actually a practice of yourself. You actually, as a practitioner with the team, implement and practice human-centeredness on yourself, on your team, and this actually permeates also in how you end up changing yourself, your own practices, and the practices of people in the community of individuals as well. That's a very profound way of looking at public health practice and public health systems. So Liz and I prepared this overview of the interdependencies or components of the levels of the infodemic, the perspectives of how one needs to look at the infodemic. This is actually a simplified version of what was discussed a couple of weeks ago at the WHO Infodemic Management Conference, when we met with health authorities and academia, specifically to look at, well, how do we improve metrics? How do we create measurement and monitoring systems so that we could have a better sense of what the burden of the infodemic is? And what you see here is at least 4 levels of complexity when we think about what influences the infodemic elephant. One is the information ecosystem. We, in a digitized society, are affected by the information ecosystem, online and offline, that provides us not only with information, but allows us to have interactions with people, and and also creates different identities. The way that we have different identities, different roles in our lives, professionally, as a mother, as a member of a community, member of a church congregation, etc. So do we actually build identities, and also online, and we project them in different communities that we build. So the information ecosystem is a big part of how we need to think about the infodemic and how the infodemic influences people's behavior. Then there's a variety of factors that are marked in blue. that relates to what drives the effects of the infodemic on people's individual behavior. So, and this has to do with how people search for information, how they feel about information, how they process it, and how that information then manifests in direct health behaviors, but also in other kinds of direct or indirect psychological effects, for example, anxiety or stress related to, for example, power dynamics in the family, etc. And then the third level of thinking about the infodemic and the effects has to do actually with the health system effects. So we observe a variety of disease states or even deaths related to the infodemic, not just lack of information or misinformation, but the way as a consequence of how people interact with information, make decisions, and enact health behaviors. Health system also spends a lot of effort in the public health prevention activities, trying to influence individual behaviors, right? And those are also activities associated with cost, but also can be levers that we can use in order to promote health behaviors. And then there's another big chunk, even bigger chunk of the aspect of the infodemic that interplays with the health system in a feedback loop. And this is also the wider economic effects of the infodemic, and this is wider societal impacts of the infodemic. And this has to do, and this is getting more and more complex. I think we've seen it also throughout the evolution of the COVID-19 pandemic, because what people experience in their livelihood or through their ability to provide for themselves, their families, the stressors they have in their own environment related to the their economic and social status, those stressors are part of the people's decision-making process, and that leads also to an enabling environment that leads people to enacting health behaviors or not. So these are four big chunks of perspectives that you as an infodemic manager need to think about. Also when trying to solve the issues that you diagnose. And Liz, would you perhaps discuss the questions to consider?
Sure. So often when we're thinking about designing around humans and we want to encourage a specific behavior, we need to understand, walk a mile or walk several kilometers in the shoes of your target audience, understand what about their experience is particularly difficult or hard or painful, and working backwards from there. What are the barriers that people face between what they're doing now versus what you want them to do? And then what can you do to lower those barriers? And so just to recognize, there's not going to be a single intervention that Tina and I will talk to you about, spoiler alert, that will answer all aspects of this concept map. There's not one infodemic management intervention that will cover the entire field. So you really have to be specific as to what part of this concept map will you try to influence, and also what area does the health authority have the most influence over. So, you know, I would argue that generally speaking, health authorities have way more influence over the red part of the diagram as it relates to the health system versus maybe the green, where we're talking about the wider information ecosystem. So just recognizing that there might be a lot of different aspects to the infodemic on this concept map, but you might not have a reasonable degree of control over many of them. So you are not able to actually address a lot of the contributors to stress, to pain points, to risks or concerns that might be contributing to the wider infodemic and to people's behaviors. So you really need to focus. Where can you do the most good? And then also think about what are some of your menu of interventions that are available to try try. And we'll talk about what that list of interventions types looks like. And then ultimately, what is it that you want to measure? And then when you figure it out, how do you measure if it works or if it doesn't work? This is really critical because we're very much in the form of throwing spaghetti against a wall and seeing what sticks. There's a lot of different innovation happening in the infodemic management space, and people are just trying stuff out because we're in a pandemic. And so, we need to do a better job of measuring what we're doing, evaluating what we're doing, and sharing that out with others, so we don't have others trying to do the exact same thing with similar results and wasting their time. So what can we do to get all of us past this emergency faster? And we can do that by measuring what we're doing, evaluating what we're doing, and sharing out those experiences.
Great, Liz, thank you. I actually want to also make an interlude here before we go into discussion about the interventions. Just to underscore what Liz said, what Howard said in the previous lecture, here's another aspect of why it's really important for us to really think about iteration, working early through iteration, working early and implementing the human-centered design principles that Howard was talking about. Actually, because I've noticed in many of the conversations that I've had, a lot of times we really underestimate how fast the information ecosystem is actually changing our society. And I would say especially the last 10 years, for example, since the internet platforms decided to, for example, move to ad-driven news feeds and start developing extremely personalized interactions for people, for example, on social media, this didn't change only how people interact with social media or internet platforms like Google and how they search for information. It changed media newsrooms and how also traditional media communicates. It has changed our society, and this basically was done within 5 years. 5 years later, by 2017, everyone was talking about the rise of fake news, the polarization, etc. This has occurred because of the information ecosystem changing, really, the digitized society. And public health and health system haven't really caught up with that. We really need to, because I just took out a couple of headlines that I picked up today that came up over the last 3 weeks in the media. The information ecosystem is poised to change very rapidly. Again, it's continuously changing. So, for example, Amazon just announced that they are building infrastructure for high-speed internet enabled by microsatellites. And that means that the future of high-speed internet in many different places will be a reality much faster than what we assume, which means that Facebook is thinking about the metaverse, which will profoundly, if implemented by one company, affect how our digitized society works. And other technologies are coming into play that are interfacing with that type of information ecosystem. Now, I'm pointing here out innovations in the digital space, but not to discount how much the innovation in technologies have actually transformed how societies, even those that are still not completely connected to the internet, have really been changed by how people work, how they interact, and how they share information. Now, going back to interventions, Liz and I prepared 6 buckets of truths for building interventions for the infodemic, specifically looking at people. And Liz, let's do a tag team here through this. One thing that you've already heard about a lot is that we really need to be systematic and integrative when we think. So just like Howard was saying, our way of thinking cannot only be linear. We need to be listening and integrating analysis and designing analysis plan based on what we know the perspectives of what we're trying to solve or perspective infodemic we're trying to address. We need to consider changes in programs, not just only in communication. We need to develop interventions. And there are models that Liz is going to show later that can help us think through this and organize our thoughts around this. So the iterative thinking process is really key. And this is a practice that doesn't come easily. to public health programs and action, but is really, really key in order to design fast. Liz, do you have any comments on this, and maybe segue into the next one?
Just to say, you really are trying to work at multiple levels here. This is really hard, and different disciplines, when we're thinking about all the different disciplines touching the elephant, have all tried to diagnose and intervene in their own narrow windows of their disciplines and their niches and their perspectives. And what we need is a holistic approach. And that's where you all come in. And this is why we constantly emphasize, not just in real life, but also in wisdom, the importance of leveraging many different skill sets, many different perspectives, and many different disciplines. You need a lot of different disciplines to be able to design our way out of the infodemic, as it were. So we're going to make your lives a little bit harder, because you might be looking for that golden list of wonderful interventions that work really well to address the infodemic, and you might be disappointed because it doesn't exist yet. That's why you are all here. If we already knew how to solve the infodemic, we wouldn't be here right now. So we're going to add a little bit of complexity to this picture, but just to say, we hope to arm you with the tools that you need to be able to design interventions and implement interventions and test them out in ways that are helpful to getting us past the COVID-19 epidemic and beyond.
Yeah, and also actually join the community of infodemic managers and collaborators and partners who are all trying together right now, share experience and move this forward. So this is really critical as a global collaboration of people that work locally. Liz, how about the focus on health behaviors?
Yeah, this is really critical. We need to focus on what is it we want people to be doing. What are they doing right now, and what is it that we want them to be doing, and how do we get them from point A to point B? Messages are probably not going to be sufficient, and you really should not assume. Again, we repeat this again and again, question your assumptions. Don't assume that because someone's not doing something, it's because they're not motivated or don't understand. Intention only sometimes translates to action. I want to see people raise their hand. For those who made a New Year's resolution to get fit and eat well and healthy, how many of you are still sticking to your New Year's resolution that you made in January? Raise your hand. Wow, Irene is one person so far. I want to see how many people's hands are raised.
Oh, Catherine.
Darglon and Tanisha and Catherine. Wow, okay, you guys are strong. People made out of strong, motivated stuff. I failed 3 days in. But that's okay. So the point is that there's often a huge gap between intention, what we want to do, or what we plan on doing, and what we actually do. And so this is really, really important, because it's not like you can push a button here and then suddenly the infodemic is affected over here, or people's behaviors are affected over here. There's a complexity of reasons and motivations about why people do the things that they do, as Howard explained. And what it comes down to is the individual. When we think about the concept map, we also want to think about the fact that the infodemic we only detect once it reaches population level. Once we see enough people doing behavior X instead of Y, that we start to notice in the system something's wrong here. Something needs to be fixed. But the infodemic acts on the individual level, and it's really, really hard to predict. Like, how did the infodemic affect your uncle or your auntie or your other family member that's sharing misinformation compared to you? You guys are in the same family. So what is it about your experiences and background in education that might be different from your family members, that made maybe your family member more susceptible to misinformation versus you? So just recognizing that it comes down to the humans in the middle of this whole diagram, and that we need to also remember that every individual lives in a community, and that can be online communities, offline communities. It can be your cultural group, your ethnic group, your religious community, your community that you work in, or at school. There's a lot of different identities that we have that are multi-level and complex. And I think this last point is particularly important, is that we often focus on behaviors of the general public and communities, but we forget to observe our own public health system's actions and behaviors that can be missing the point and reduce any chance to change final target behaviors. So I think for a lot of people, it was a rude awakening. For those who work in the health systems, the first group to be prioritized to get COVID-19 vaccines this last year were health workers. There might have been this assumption, well, they work in public health, they work in, in medical services, and, they know the importance and value of vaccinations. So why aren't they getting vaccinated? Everybody should be getting vaccinated in the health system. The fact that you had to do extra legwork to address their fears, their questions, and their concerns so that they're confident in their own decision to get vaccinated was maybe something that we didn't realize would be as big of a hurdle until it was a hurdle. So the point that we're trying to make is that we can't assume that the health system, everybody's on board, everybody is contributing in their way to address the infodemic, because sometimes those assumptions can also really shoot us in the foot. I'll give you another example. We are working with UNICEF in a country in Eastern Europe where, guess what? Nurses are actually the ones that are more likely to give you misinformation about vaccines to mothers, to parents, to caregivers, than addressing those questions and concerns that mothers and caregivers might have. And so how do you address that, when it's actually the healthcare provider that is actively promoting misinformation? So just recognizing that there's a lot of levels of the system that you need to be trying to influencing simultaneously, but don't assume that community just means some group of people out there in the public. The health system is also a community that you need to act on.
Mm-hmm. And extrapolating further on this, we also need to really rethink what are the communities we need to engage with, even within health system. There's where are the actually touch points between people and the health system, and it can be things like pharmacists, and it can be people like medical librarians who are helping patients with chronic diseases, trying to figure out how they're gonna seek treatment. And these are all things that perhaps you don't think about outside of an emergency specifically, but all of these types of interfaces or connections between individuals within the health system and between the health system and individuals in the population, all of those actually affect how people end up thinking about evidence, about their decisions about health behaviors, their protective behaviors, prevention behaviors, etc. So if you move on to the next three truths that we prepared, the next one I've already touched upon with a big slide of headlines because I really feel very strongly about it, but it's extremely important that we always keep in mind that the information ecosystem is shifting really the pre-established models and paradigms of how we look for information, how we feel about it, how we use it, and how this affects the society and behaviors at population level and people's individual behaviors. And this is being done very fast. So infodemic management as a practice and everything that we're presenting to you, it's literally a way of beefing up the public health practice to really think outside of the box in an organized and holistic way so that the public health practice evolves and our interventions and the way that we manage the infodemic is timely and effective, and therefore that we, for example, during an emergency can actually support the acceptance and the uptake of public health and social and adherence to the public health and social measures, or the uptake of recommended treatments, or the uptake of vaccines. So it's like one of the things that I feel very strongly about, for example, is that currently a lot of preparedness plans only suggest reviews of preparedness plans and the landscape analysis every 2 years. And especially when it comes to infodemic management and preparedness for this, the information ecosystem changes so quickly, especially in a country, that we actually need to really be thinking about how quickly we review and are prepared to really think broadly about all of the different aspects of the infodemic so that we are prepared. Otherwise, we are literally setting ourselves up to respond with outdated preparedness plans, for example. And Liz already mentioned that, what works, we're still learning about. The science is still working really hard. WHO last year, we set up a dialogue between the research community and health authorities to drive the public health research agenda on infodemic management. All of this is still nascent. We're still learning from experience, which is really important to to keep in mind, because this means that you will need to, regardless of what your professional background is, you will need to borrow from other fields of practice, other scientific fields, and test out new ideas, and then report back to the community, share what you've learned, so that we actually can better understand the and faster get to a package of interventions that works. And that then leads to the next point, which is that we really need to work and intervene faster. Also outside of the emergencies, the bulk of infodemic management work is in preparedness and what we do in strengthening systems. Liz, do you want to reflect on that one?
Yeah, I mean, I think what it comes down to is that, you know, you reap what you sow. And I mean, we've all learned in the pandemic how under-resourced and underprepared many health systems were for the pandemic, for the infodemic, and it really has put us on the back foot where all we're doing is constantly just firefighting. And that makes it really difficult to be effective in infodemic management when you're trying to build partnerships and build trust in the middle of a pandemic with communities that might not have a lot of good reason to trust. And so you have to balance this idea of like, what is it that we're able to reinforce and build now into the system for next emergency, next pandemic, and what is it that we can do now? I think it's also really important to recognize that, again, our brains work differently in emergencies. So Richard talked about this during the CIRC talk on Tuesday, and also recognizing that we can only do so much really to move the needle. Most behavioral interventions for any part of particular health, encouraging any kind of health behavior, you're probably talking an improvement in uptake of single digits. There's going to be very, very few interventions anywhere in health where you're going to have, you know, dozens of points of percentages of increase of uptake of a specific health product or health behavior because you did one intervention. So usually it's cumulative. And I think that also kind of goes to the idea that you have to be comfortable with the idea that one intervention will not dramatically change behavior or fix the infodemic. How do you make an elephant do what you want it to do and do it willingly? And assume that we don't like abusing animals and that you can't just poke it with the stick to make it go in the direction you want it to go. So how do we make the elephant move and make it feel like it's its own idea to move? And that's probably going to require a lot of different interventions simultaneously to make that happen. And then I think this is also really true. Be comfortable with the idea you'll never have enough information of high quality to take perfect actions or to build splendid interventions, especially in emergency. To quote a famous American GIF, nobody got time for that. Like, we just do not have the luxury of time to do things as deliberately or as deeply or as thoughtfully as we would like. And so sometimes you have to really think, what is sufficient and enough to be able to act on, to be able to create better interventions, better guidance, better messages, better communications and programmatic interventions. Sometimes you just need something that is sufficient and maybe not overwhelmingly perfect, and that's okay. We are working at pandemic speed and we will continue working at pandemic speed. And Tina, I think you have some thoughts on the last point, especially around unintended consequences.
Yes, so this is, we really need to be thinking very carefully about the ethics and the values through which we implement, design and implement any intervention. In the discussion online, for example, about the moderation and the content moderation of social media, there's lots of discussion about and concern about any type of policy interventions that may end up being misused for curbing freedom of speech, for example. That is an example of sometimes of a well-intended policy or law that gets introduced that, if not really considered from the ground set of how actually an intervention would affect not only people's very narrow behavior, for example, of sharing information, but how that may actually impact the wider wider society, you can end up getting in trouble. So something that we end up doing to address a particular piece of misinformation or any pain points that Liz is gonna walk you through may end up influencing a person, an individual, and have a very detrimental impact to their livelihood or their way of connecting to a community that they feel strongly about. So, for example, why are the coercive methods of, for example, the vaccine certificate mandates coming up with such a strong opposition by some people? Is because if they perceive it as loss of control over their own actions and their own behavior, there will be a part of the population that actually will end up not just rejecting the particular mandate, but it will harden their mistrust of other mandates and other interfaces with the health system. So we need to be really careful when we're selecting what interventions for what type of pain points that we're trying to introduce, so that we don't actually have more unintended consequences in people's lives that end up actually completely countering the intent of what we tried to do. So I consider this really as an ethical question of how we work. This is not, a theoretical or behavioral design context. We as practitioners, actually public health practitioners, need to be extremely committed to, at the outset, practice these ethical values of we are trying to understand the human, their drivers, what are the barriers for them to enact health behaviors, and then really empathically and holistically address all of the environment around them in a way that actually enables health behaviors by people, instead of them feeling that they are punished or coerced into some action. This is just an example of this, but yes, I feel very strongly about this, because sometimes it's extremely easy to lose sight. Following checklists, following frameworks, it's very easy to say, okay, fall into a process to just push things out. But really, listening also to what Howard was saying earlier about human-centeredness, that empathy, that iteration, that self-reflection, it's not only about thinking about the person that we're trying to influence, it has to also be something that we ourselves practice ourselves as well. Liz, would you like to run us through the behavioral interventions and frameworks?
Yeah, so I'm gonna put on the Howard hat for a second. So just to say that behavioral models can be useful for understanding the reasons why people do specific things and can suggest what interventions might address specific barriers. This was from the same presentation that Howard gave about the behavior change wheel, which harmonizes findings from many different behavior change frameworks, including those used for tobacco control and obesity. It can also be useful for infodemic management interventions. This is not to say that this is the perfect framework to use to planning for all the infodemic management things. It is just one of many. And I'll quote Howard here: all models are flawed, but some models are useful. This one is useful because it also provides interventions and policy categories. So let's walk through this pretty quickly, but there's more information in the bottom there if you'd like to get really, really deep into how this particular model works. Next slide. So let's talk about how we might think about behavior. So this is called COM-B, and this kind of makes the core of this behavior change wheel. And it's you think about capability, opportunity, and motivation, and how that leads to behavior. So capability is what is that person's ability to literally do the thing that you want them to do. And then opportunity, or what are the opportunities or ways in which they can do those things. And motivation, what is the thing that is intrinsic or extrinsic, so inside of you or outside of you, that is motivating you. So to give you like a really easy example, in the US, there's a lot of different ways we're trying to encourage people to get vaccinated. And so early on, there's a lot of focus on addressing access issues. If you're an older person and you don't have a car and you're living in a rural community in the South, we need to think about access issues. So how do we make sure that people are physically able to get to a vaccination site, or that vaccination services are brought to their doorstep? And that also is linked to opportunity. So how do we make sure that they have the opportunity to get vaccinated, make it as convenient as possible, and make it as available as possible, not just being physically close to a vaccination, but also that there's multiple opportunities to get vaccinated, whether it's in the workplace or at the health fair or at the farmers market, that there are multiple opportunities to offer that. And then motivation, how do we motivate people to get vaccinated? And there are different motivations for different people. So for example, we saw an uptick in vaccinations after the Delta variant really started circulating in the United States in late July. And it was partially because of this increased risk perception of, geez, this is really serious. I need to get vaccinated. So this motivated some people who might have been waiting and seeing or on the fence. They got motivated. For others, it's, hey, get a gift card if you get vaccinated, or drive your car on the Talladega Night Speedway in Alabama if you get vaccinated. So different strokes for different folks, but all of these different aspects linked to behavior. But how does this relate to infodemic management? So when we think about our 5-step process, your social listening insights in step 1 can help you determine what your target population's capability, opportunity, or motivational factors might be at play, as well as larger health system structural and policy forces that impact their behavior. This will also shift constantly, requiring more updated programming and communications. That's in step 2, and more rapidly deployed interventions and monitoring in step 3. Infodemic managers can leverage social behavioral insights and other data sources for speedy action. The emphasis here is speedy. And let's go to the next slide. So we were talking a little bit about this, about how you fast twitch muscles and you have slow twitch muscles. Usual social behavioral diagnostic tools and approaches in public health to determine why a population is not enacting a certain health behavior can take years to implement. In an emergency, we have to move faster. It's a rapidly changing environment, more communities of concern, changing data and insights that really need to be usable by health authorities and not just for academic audiences. Some diagnostic approaches need to be adapted for use in emergencies to deliver faster insights and programming. Again, what that means is that you're sacrificing depth for breadth. And that's just the reality of working at an emergency, that you just will not have enough information of sufficient depth or quality for you to feel super comfortable that, an intervention that you designed is going to be the perfect intervention to address the issue. You have to do your best, and this is going to be a judgment call. And then it's really important, embedding behavioral scientists and infodemic management teams is necessary to build a human-centered public health system, especially for those systems that are in that sturdy 4x4 category, or if you're lucky enough to have a luxury vehicle that you're driving in. Behavioral scientists are really, really important, and they're even rarer than unicorns. They're rare as hen's teeth. If you're lucky enough to have a behavioral scientist available to you, grab them with both hands. They can be really critical for helping shape and understand some of those aspects of human culture and communities and the human issues that you won't be able to get out of CAP survey. And I think Howard really pointed this out, that often the data sources that we have on people's questions, thoughts, concerns, feelings, and emotions are not sufficient, and we need to sometimes do extra data collection, which goes to the next slide. So hat tip to WHO Euro tip. So TIP is Tearing Immunization Programs, which are a series of tools that can be used to diagnose reasons for under-vaccination in specific populations using the COM-B and the behavior change wheel. I highly recommend it. There's a fabulous group of behavioral scientists that work in WHO Euro that have created this, this tool, and the link is there. And so it's really useful guidance. And what I will point out, though, is that this process can take up to 2 years. We don't have 2 years. So what we've done in the United States at US CDC, we've taken TIP and we've made a baby version of it called a rapid community assessment, where you can essentially do this type of work in 3 weeks, just because we have to move faster. So the TIP is fantastic if you need depth, but we need sometimes a little bit more breadth. So get inspired by this tool. It's really useful. You can easily tailor it and customize it to what you need. Highly recommend it as a primer for how you can leverage social and behavioral science insights for action, not just for immunization programs. This also can be useful for other health program goals as well.
And just to reinforce what Liz just said, with the innovation that we are all doing together, including with a social behavior scientist, is actually how do we innovate methods and ways of working that we can be faster and still be effective, that we still have enough breadth and satisfactory precision that we can then move forward with health programming, with policies, with interventions, while we are, of course, in the back of on a separate track, working on tools and methods that will be much deeper, that will be able to predict and quantify the outcomes of a particular, the impact of a particular intervention, etc. So we cannot wait. So we're working on double tracks, and the importance of working with behavioral scientists and everyone actually in your team is to innovate and find ways of working faster, effectively, and intervening faster, effectively. So let's move on to the pain points, Liz.
Yes, absolutely. And just one more note: if you're looking for a behavioral scientist and you're looking under rocks and other things, looking behind corners trying to find them, you will most likely find them in HIV programs, in chronic disease and health programs. You'll find them health promotion. You'll find them in immunization programs occasionally. So you can find them. They just might not necessarily be, in the emergency response cluster. So look for them where you can.
Yeah, and when I've spoken to them, they didn't really see how they connect to the infodemic until we started talking. And this is actually the challenge. The expertise that we have available in the health authority sometimes is hidden, and we actually need to actively connect the dots and explain, because actually the things that we're explaining is actually how other programs have been thinking. EMR, for example, has a huge behavior change component to that actually is also explaining very similar approaches. But what we need now is not only to connect with other programs across the health authority that are doing this work and the expertise. What we're saying is we need to now also add this much more systematically to the public health practice and the public health system. So this is being done in pockets in many different contexts. Expertise is in health authority in many different pockets. What we need to do is go the next step further and reinforce the public health system as a whole. And this is why, for example, thinking about, okay, pain points, other colleagues across the health authority may actually be able to identify themselves in some of these pain points because they also think about them, but maybe not holistically. Liz, would you walk us through?
Absolutely. So when we think about pain points, here's some domains you can explore in step 1 in that social listening component and in the integrated analysis to understand why there might be a gap between health guidance and what a population might be doing. So consider what people are feeling. What are they confused about, worried, angry, happy about, have other strong feelings about? What do people know? What are their knowledge, attitudes, practices, and beliefs? Where are the information voids? This is important, both the blind spots for you as a health authority or those that are trying to understand the infodemic, but also what are people looking for that they can't find? Think about how official guidance is being shared, how it's being discussed, how it's interpreted or remixed. And then think about how people are behaving or signaling related to a recommended health behavior and focus on the why. So you can think about, digital footprints and behaviors such as mobility data, for example, looking at video, image, and text reactions, hashtag use. Are there alternate behaviors? And we'll talk about this later. Think about what efforts are being tried by health authorities to support specific behaviors. So what are health authorities doing beyond messaging? How are they making it easier for people to do the thing that they want people to do? What seems to be working? What seems to not be working? Look at health service uptake and use data patterns and outliers in health status reporting to understand where's the gap between maybe what you're hearing online versus what is being reported into the health system. And is there a difference between popular perception versus reality? This is really important to understand because at the end of the day, it doesn't matter what the reality is if the perception is shaping people's behaviors. I'll give you an example. I work very closely with our vaccine safety colleagues, and they see our role as being really important about having a really strong vaccine safety surveillance system in the United States, and of course supporting our colleagues in other parts of the world who also do vaccine safety work to ensure that all the vaccines that are available are safe, and that we continue adding to that body of literature that says they are safe, and to detect signals if we think that there's some sort of vaccine safety concern and be able to respond quickly. The problem is that you can say all day long to a group of people that vaccines are safe and they're effective, but that doesn't matter if the popular perception of the safety of a vaccine is dramatically different than what the reality is based on what our reporting data says. So I sometimes have to reiterate the fact is you can say that the vaccines are safe all day long and point to a huge pile of literature that says that, but it doesn't matter if the general public doesn't perceive the vaccines to be safe. So sometimes there's a difference between perception and reality. And to be honest, as an infodemic manager, you need to understand where there are those gaps so you can address them. And then think about what are the internal pain points within the health system or emergency response that might make it difficult to update communications and programming. There are many pain points. I can tell you that from firsthand experience. A lot of that has to do with clearance. A lot of that has to do with whose role or responsibility is it for one health authority or one part of US of government to do it compared to another. For example, what can CDC say versus the FDA versus HHS versus WHO versus what's delegated down to states and jurisdictions in their health departments. So it's really important to understand where things are going wrong and where things seem to be a lot harder than they should be, and try to add some lubricant, some silicone lubricant to those places so you make it easier for people to overcome these barriers and pain points as much as possible.
Yeah, so we're trying to speak slower than usual. This is why our lecture is a little bit longer. So we have this example to show you. After this, we'll go to break, and then we'll actually have others talk about what they've been doing during the pandemic to get you a little bit inspired. So the example of all of this thinking that Liz and I prepared for you is the misinformation that's been circulating about unproven treatments, which has contributed to ivermectin overdoses and medication shortages in many countries. And this has been in the headlines across many, many countries in all continents. So this is a recent example. So for example, what are, for example, the pain points that you can pick up as an infodemic manager in the green box in the information ecosystem? For example, the social media is promoting an ivermectin in certain groups online, whether they're particular social media groups or certain groups that are linked towards that are linked also through, I don't know, algorithmic content promotion. So those groups are often linked with conspiracy thinking and actually are not specifically looking at medical misinformation. They're actually it's reinforcing of the worldview. I've already mentioned algorithms. So social media algorithms may be promoting this highly engaging content, including content about ivermectin and the controversy. Search engines, for example, may offer ads for ivermectin prescriptions when someone is looking for ivermectin information. This is all ad-driven design of the information ecosystem. Or for example, message framing around ivermectin that we may be using includes includes resistance to medical coercion or protecting medical freedom. So it plays on these views of people when they receive the information. So this is the information ecosystem part. And then Liz, how about the individuals?
Yep. So people are searching for alternative treatments and find alternative health information. So when people are looking for information about ivermectin because they heard about it from a family member or friend, they go down rabbit holes online. Of course, if you have a history of mistrust between your community and the health authority, this is just going to lean into this narrative even more. And so what's interesting is that in the United States, we've seen more news coverage and narratives about people who've had family members who've come down with COVID-19, who end up in the hospital, and then the family is advocating for use of ivermectin being prescribed to the family member that has COVID-19. And we'll talk about what kind of societal impact that has. But the point is that it's fueling this online narrative that the health system is not looking out for you. It's not the rights of the patient or what the family wishes or wants. And that also goes to this next bullet point, that some feel a degree of control over their health by choosing ivermectin themselves versus getting vaccinated, which is something that is done to you. And so this is really important, is this idea of agency and people feeling like, I want to do the thing that I think is best for myself. And so you have some degree of control about what you take by mouth because you buy it over the counter or you buy it online, versus showing up to a health facility or a pharmacy and having someone vaccinate you with a needle. And I think there's really something here that really gets at why people might choose one thing over the other.
Mm-hmm. And this is actually, in general, a big challenge if one looks into the health and wellness communities online. A lot of the reasoning and for example, brands, the personal brands that the health and wellness influencers are promoting actually touch on this point that Liz just mentioned. But here's the one, this is the one part of this mapping, the grouping, that most of the time no other discipline is tackling. And this is, what can you observe from within the health system? So we can observe deaths from ivermectin overdoses. We can observe increased poisonings being reported through various systems of the health system. We can see increased calls to poison control hotlines related to ivermectin overdoses and poisonings. Increased hospitalizations, for example. Also, which is really important and sometimes overlooked, delayed and missed care for COVID-19 infections because people were self-treating at home, which means higher morbidity and higher. Can someone please mute the colleague? Thank you. And then there's other things. For example, you could observe increased prescriptions for ivermectin by doctors for human patients, which has occurred. And or for example, veterinarians reporting that they stock outs, which actually then affects livestock health. And then Liz was mentioning, you know, on the societal level, you can then pick up and see litigation, frivolous litigation related to people demanding ivermectin treatments versus and basically hospitals or practitioners having to deal with frivolous lawsuits. This actually happens also everywhere, not just in this case as well. And of course, one big societal issue that also is associated with it is that because there's an interest in ivermectin and it's being used, this actually indicates that a mistrust, an ongoing mistrust of public health guidance, which then is something that one needs to address not only through this particular piece of misinformation or acting on it, but actually really needs to be considered as a whole. So we are here for a Slido break before we end up going to a real break. We wanted to ask you, what do you think would be some solutions for to address this ivermectin case? I will switch the projection to Slido just a second, and let's see what you guys have answered here.
So, I mean, maybe just to highlight that this is an issue that we've been tracking in the US. I don't think we have any great solutions just yet, but the point is that this only really became majorly apparent when a health a HAN was issued, basically a health alert was issued saying that a huge number of prescriptions for ivermectin were being reported, as well as overdoses. And working backwards, of course, we had recognized that ivermectin was peaking as an area of discussion online months before, but it's only in retrospect that we're able to figure out how these pieces are connected. So I'd love to hear what your thoughts are and some solutions that you might, how you might address this particular issue if you were in our shoes. So one person says side effects. What else? People are probably frantically typing.
Or thinking. I mean, the difficulty here is, you know, the breadth of the considerations. And again, there's no perfect answer. So we're in the brainstorm stage of what Howard was describing. Just throw things out there. Yeah.
I think one of the challenges with ivermectin that makes it unique compared to some of the other issues, and I think hydroxychloroquine, this also was, there's a bit of this then, but this idea that there was early research into the use of ivermectin and hydroxychloroquine in trials for treatment of COVID. And so to some degree, there is basically what we know is the science says that it doesn't work for treating COVID-19 or preventing it. But the point is that there's scientific papers out there where this was clearly trialed last year. And so that is used as a underpinning to make it sound more scientific, the reasons why ivermectin should be considered a viable treatment or cure. And so it becomes this reinforcing narrative, unfortunately. So information ecosystem, pre-bunk and debunk, as well as inoculate, reinforce at contact points, health system target physicians, and public health volunteers. Absolutely. Not all studies are equal. Debunking myths using key influencers, trust issues with other drugs that government might endorse. Same thing happened with hydroxychloroquine. Absolutely. Yep. So personal stories from the people who overdosed. That's a powerful one. Awareness raising. National COVID task force should label ivermectin use as unsafe and as harmful, especially with overdose. That's interesting. Provide accurate information, provide physician opinion and testimony, work with pharmacists, human stories.
Perhaps also work with those physicians that are prescribing the drug to humans.
Yeah. I think I saw a statistic that's something like it was like a 24-fold increase compared to last year about the number of ivermectin prescriptions. And the jarring thing is what's probably happening is that people are going to their doctor saying, hey, I'd like to get a prescription for ivermectin. And the fact that you had tens of thousands of prescriptions being written, like, how did that conversation go between the doctor and the patient? Like, well, yes, that sounds great. Let me write you that prescription. At no point did the physicians like have a conversation with their patient, be like, well, why do you feel this way? And what is it that you're trying to protect yourself against? Maybe you should consider getting vaccinated or some other type of proven way of protecting yourself. Rapid action might not always work. And so these are some, we asked for bad ideas.
Yes.
Harsh lawsuits, bad mouthing people, shaming people, limiting access or removing from the market, shaming and blaming.
Yeah.
This is very interesting. Okay, you guys are on fire. Good job.
Good job. So let's just show the types of interventions and then go to break. And I just need to reshare the screen. And okay. Liz, you're on fire.
All right.
You can continue.
Dun, 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 dun. All right, now we're going to whip you through the categories of interventions. So these interventions can be easier and quicker to implement to make small improvements, but the outcomes or impact may be harder to measure. It's likely you'll need to do multiple things simultaneously for a higher degree of impact. So this is the universe of intervention categories. This is not to say you should be doing all these things or that some of these are necessarily the right answers. Depends on the question and depends on what your issue is that you're trying to address. So some of these are self-explanatory around education, persuasion, incentivization, coercion, training, enablement, modeling, environmental restructuring, and restrictions. I'll talk about very briefly about the ones that are not so obvious. Coercion, this can include things like workplace mandates and requirements, for example, or throwing people in jail who share misinformation. That actually has become laws on the books in several countries, which of course can be concerning for a variety of reasons beyond trying to address a public health issue. Enablement is this idea of like, how do you make it easier for someone to do the thing you want them to do? So back to my example of like, if you're an older person and you have access and mobility issues, having vaccinations being brought to your doorstep by mobile teams might be a better strategy than trying to get you to a vaccination site. Modeling is this idea of like modeling the behaviors that you want people to be doing. And so that's where like social influencers come in and really making developing a social norm to support a specific behavior. Environmental restructuring. So this can be literally like changing the architecture of the space that you're in, but it can also mean like thinking about the environment that you're structured in online. I'll give you an example. I was in India in 2018 for their measles rubella campaign, where they vaccinated 500 million children. And between phase 1 and phase 2, they ran into huge problems on WhatsApp of lots of rumors circulating on WhatsApp. At the time on WhatsApp, you could hit forward on any kind of post that someone made, and you could send it to everybody in your address book if you wanted to. So with one touch of one button, you could send it to thousands of people if you have thousands of people in your WhatsApp chat. And so that was a problem. And this continued being a problem to the point that the Indian government told WhatsApp, unless you change this, we're going to take action. And what they ended up doing is that now you can forward it to 5 people. So you can forward it to 1,000 people, but you have to do it 5 people at a time. So that one user tweak in terms of the design experience added friction to your ability to share it widely very quickly with a lot of people. And so that's one example of how you might restructure the environment to make it harder for people to share misinformation. And restrictions is another one, like limiting a particular intervention for a particular group of people. And so that's another thing. I do want to emphasize here that acceptability of interventions is really critical, as well as understanding what the possible unintended consequences might be of using some of these intervention categories. So just be very, very thoughtful and considerate. Then there are also policy categories. These can be more expensive and they can take longer to implement, but they can have lasting system level effects and maybe easier to measure impact because you're collecting data on this at the systems level. That's regulation, service provision, legislation, marketing and communication, environmental and social planning, guidelines, and fiscal measures. So for example, one example of this in the United States is that up until recently, most healthcare providers were not actually being compensated for time that they're spent counseling patients about their vaccine questions, concerns, fears, and misinformation. So basically a doctor was taking time out of their day doing that for free and hoping that that person gets vaccinated. So that doesn't necessarily incentivize a healthcare provider having that conversation, addressing those concerns to get someone vaccinated, because the only thing that they were getting paid to do was to actually get someone vaccinated. So thinking about how you might be able to use fiscal measures as a way to encourage the desired behaviors that you know would create that supportive environment for people to do the health behavior you want them to do, it can be really powerful. And so we kind of give you a whirlwind tour around both of these sets of different types of interventions that you can consider. But when we come back after our 3 inspirational talks, we are going to take this approach, this COM-B model, and the behavior wheel, and we're going to apply it to a specific case example.